Okay, this is peripheral nerve problems video 2, and we're on trigeminal neuralgia. A complete neuro exam, including things like audiology, CAT scan, lumbar puncture, MRIs, and EMGs, may be done to rule out other pathological conditions. And then we look to see how we can help deal with this painful situation. Anti-seizure drug therapy is considered first line. In particular, carbamazepine, which is Tegretol, is a level A recommendation for dealing with the pain of trigeminal neuralgia. It is a sodium channel stabilizer. Some side effects for that medication can include bone marrow depression, so the patient will have CBC counts that are checked very routinely. The dose will be increased as needed and tolerated, usually to levels of 200 to 1,200 milligrams per day. About 70% of patients will have a response, a positive response, with Tegretol at those dosages. If Tegretol doesn't work, oxcarbamazepine, which is a form of Tegretol called Trileptal, may be used. It's a level B recommendation. The dose range on that is 600 to 1,800 milligrams. Pretty beneficial, but the side effects are less severe and less frequent than with the first drug. If neither of those work, then there may be some medicines that are tried in combination. Lamotrigine may be used in addition to the Tegretol, or sometimes they'll go ahead and switch them to baclofen. Baclofen is a muscle relaxer and an antispasmodic. It's not an anti-seizure drug. Precise mechanism of baclofen is not understood. It falls down as a level C recommendation. Let's see what else. Wrong direction. Okay. Nerve blocking. We'll talk a little bit more about these. Biofeedback. Nerve blocking with local anesthetic results in a complete anesthesia of the area for about 6 to 18 months. Biofeedback is helpful for some people, and it does provide a strong sense of personal control. And then there's surgical therapy that include glycerol rhizotomy, percutaneous radiofrequency rhizotomy, the microvascular decompression of the gamma knife, and I've got some slides about these. The glycerol rhizotomy is an injection of glycerol through the foramen ovale into the trigeminal cistern. If you look here, a needle is inserted into the skin beside the mouth, and it's directed through the foramen ovale to get to the Gasserian ganglion. The glycerol that's injected will produce a mild injury to the nerve. It causes minimal risk of permanent facial muscle numbness. Most patients get early relief with this technique, but about half of them will have a recurrence of pain. This is a coronal CT showing the foramen ovales. That's where the needle is targeted to. I thought that was pretty cool. Percutaneous radiofrequency is another procedure. This procedure has to be done with the patient awake enough to describe the degree and extent of facial numbness. So they get some IV sedation, and thermal injury is applied to the nerve. This form has the best long-term pain control. About 75% of patients are free of pain after 5 years. Now, long-term success is dependent upon some degree of facial numbness, and sometimes something called anesthesia dolorosa occurs. The pain of anesthesia dolorosa is severe and constant, and it's described as a burning, gnawing, or stinging following injury to that trigeminal nerve. Microvascular decompression surgery alleviates the neurovascular compression. They'll place an inert shredded Teflon between the offending vessels in the trigeminal nerve root. You can see it here. Remember we mentioned earlier? So there's the blood vessel, and then here's the nerve root, and so a little piece of Teflon is placed between those two to lift off the blood vessel off the nerve. Here's the incision location. And then this is a picture showing the brain opening. Now, complications of this surgery are extremely rare if it's done at centers where they do a lot of these surgeries. The long-term success rate is equal to or superior to your percutaneous procedures, and they don't have the higher rate of permanent nerve outcomes like numbness. But because, you know, it is a operative, a craniotomy, the surgeon actually visualizes the trigeminal nerve as it arises from the brainstem, so you can end up with complications related to that kind of surgery. Okay, gamma knife radiosurgery is a pretty new technique. It allows for focused radiation to be delivered to the trigeminal nerve root. Similar to the percutaneous rhizotomy procedure, gamma knife radiosurgery is done by putting a frame on the patient's head, then getting an MRI, then putting the person in the gamma knife, and then they'll do cobalt radiation at the trigeminal nerve. There's a delayed injury on the trigeminal nerve, and it reduces the neuropathic pain within a few weeks in most patients. Higher doses of radiation may produce better pain control, but you do get risk of facial numbness and other side effects. Details regarding long-term effects and risks of this kind of radiation therapy is still being studied. Now, the next things we look at here are nursing management. And when you look at these diagnoses of acute pain, nutrition, anxiety, impaired oral mucous membranes, social isolation, and impaired communication, and the planning, keep in mind the nursing management is well described in the chapters, very understandable in the context of the diagnoses and these planning goals. Okay, that is it for trigeminal neuralgia. When we come back, we will talk about Bell's palsy.